Hello and welcome to Northwest Missouri Area Health Education Center's December Health Career Chat. Thank you for joining us tonight. My hope for this workshop is to provide opportunities to learn more about in-demand careers in healthcare, meet healthcare professionals, and learn about the education required to enter different careers in healthcare. I'm going to say healthcare a lot in this presentation workshop, so bear with me. My name is Savannah Left. I am the Health Professions Coordinator for Northwest Missouri AHEC. Tonight we will be discussing careers in surgical technology and radiologic technology. To lead these discussions, we have North Central Missouri College Radiologic Technology Program Director Mallory Han and future NCMC Surgical Technology Instructor and Program Coordinator Jeremy Wilson. They will be answering questions tonight about their careers and about the education required to get into these careers. Mallory Han is from St. Joseph. She graduated from Bishop LeBlond High School. She earned her Radiologic Technology certificate from Hilliard Technical Center. She also holds a Bachelor of Arts in Healthcare Management and a Master's in Education Administration. She worked as a radiologic technologist from 2004 to 2009. In 2009, she began as a professor at NCMC. Since 2015, she has worked as the program director for the Radiologic Technology program and was recently hired to start the brand new program based in Savannah. And again, we have Jeremy Wilson. He is born and raised in Savannah. He earned his certificate for surgical technology from Hilliard Technical Center. He's also earned a Bachelor of Science in Education. He has worked as a surgical technician at Mosaic Life Care and at St. Joseph Center for Outpatient Surgery. And he began as a surgical technology instructor for Metropolitan Community College in 2019. In January 2022, he will transition to start NCMC's new Surg Tech program in Savannah. Mallory and Jeremy, do you have anything else you'd like to add about yourselves? All right, then we will get started with the first question. So what is your job description and when and why did you know you were going into this career?
Savannah, I'm supposed to answer first, is that right?
Yep, we can do that.
Okay, so the job description for a radiologic technologist is pretty broad, but basically radiologic technologists are skilled in the theory and practice of the use of radiation for diagnosis and treatment of disease. Specifically, the background that I'm from is for the diagnosis of disease, but radiologic technologists also work in radiation therapy for treatment of cancer. And we do lots of other things in addition to helping with diagnosis. We do things like positioning the patient in the proper manner. We also provide basic patient care. Okay, can you all hear me now?
Perfectly.
Okay, good. So I'm going to leave my video off because it seems like maybe I do a little bit better that way. As far as the second part of that question, asked when did I know that I wanted to be as a person in the profession? I actually knew in high school that I wanted to be in healthcare. I just wasn't sure where I wanted to be in healthcare. I did some job shadowing and talked to a lot of people that I knew in the healthcare field. And that was when I determined that I wanted to go into radiologic technology.
All right, thank you. Obviously, job shadowing and doing any of that stuff is really important for helping with your career decisions. So all of you guys remember that. Jeremy, same question for you.
All right, so basically the primary job description of a surg tech, like what everybody thinks of whenever they think about surgical technologists, is essentially what our job is we work in the operating room. So basically what we are responsible for is we're responsible for gathering all of the equipment and supplies for a upcoming surgery. And then we are responsible for opening that supplies. The primary, one of the main terms you'll hear with surgical technology is aseptic practice. Basically, that means sterile practice is what that more or less means in a nutshell. So we are responsible for setting up the sterile fields in the operating room and getting all of the instrumentation ready and prepared for the surgeon, helping with positioning of the patient if that's necessary. A lot of the time, by the time the patient comes into the operating room, we're already gowned and gloved, so we're considered sterile individuals in the room at that time. So a lot of times when it comes to positioning of the patient, we don't actually assist in that because there's no way for us to do that without contaminating ourselves and having to start with gowning and gloving again. But essentially what we do is we get everything ready. And then once the surgeon comes in, essentially we pull up to the field. So we are one of the, there's always at least 2 sterile team members in an operating room. There's always at least the surgeon. And then there's always at least 1 surgical technologist to assist the surgeon. There can be 3, 4, even more people in the room that are actively working in the sterile field, but it just depends on what the case is and how much, like basically how in depth is the case. If it's a small case like a lesion removal or whatever, a lot of times it will just be you and the surgeon. But most cases, the surgeon's going to have what's known as a first assist or something along those lines. So they're going to have another individual there basically as another set of hands and eyes to help the surgeon out. Primarily what we do is we do anything from passing instrumentation, passing of medication, holding of retractors, basically anything that the surgeon requires for us to do. So it is very important to be like, you don't have to be like really dexterous with both hands, because I'll be the first to admit that my left hand is definitely my weak hand. If I can choose to pass, I'm going to choose to pass with my right hand. But if the surgeon asks you to hold a retractor with your right hand, now you're only got one hand. So you have to be able to function with both hands as far as passing of instrumentation. So a lot of what we learn is essentially what are the instruments, what's the appropriate way to passing of instrumentation, setups, and then we learned a lot about all the different surgeries as well, so that we can be the best and most efficient as we can. There's a lot of things that you have to learn as a employee. Basically what we focus on in the program is getting you ready and teaching you the basic skills that you need to be able to go out and get a job and function properly as a surgical technologist. And then at the end of the case, basically what we're responsible for then is breaking the room down. So basically we're going to separate all of our instrumentation out, clean and dirty. So basically we can send it over to sterile processing so that they know what has actually touched the patient. That's considered dirty. What we consider clean, it hasn't actually came into contact with the patient, but it's still not sterile anymore. It's been opened in a room. They don't have to do as deep of job scrubbing that instrumentation because it shouldn't have blood or bodily fluids or anything like that on it. And then essentially what we do is we break the room down, go and get the supplies for the next surgery, set it up again, do it all over again. So as far as the second part of that question, I didn't actually enter into the medical field. I graduated from surgical technology school when I was 35 years old. Essentially, the medical field always kind of was interesting to me, but I wasn't for sure that that's what I wanted to do. Like basically, what I saw as the medical field was like the common things. Like I've always said that surgical technology is something nobody knows what we do. Everybody knows what a rad tech is. Everybody knows what a nurse is. Everybody knows these common jobs. But then a lot of the times you'll say surgical technologist and people are like, well, what is that? They have no idea what we do. But once I learned about that job, I found it very interesting. It was something like kind of the whole, essentially we work in an environment that not everybody can do. Some people will pass out or whatever, they just can't handle the environment. So like I kind of like the idea of working somewhere that a lot of people can't handle. So basically I was probably 32, 33 when I decided that I wanted to do the program. And then it took me a couple of years to get around to actually doing it. And I've been doing that ever since then.
All right, awesome. So you said that you hadn't gotten into surgical technology until a little bit later in life. Had you previously worked in healthcare before then?
No, I'd never worked in healthcare ever.
Okay,
My wife's
so
a nurse, like a lot of like cousins and aunts and whatnot that are in the medical field, but I personally had never worked in the medical field.
Okay. How about you, Mallory? Did you have any careers in healthcare previous to radiology?
No, I walked out of high school at 18 in May, and I walked into x-ray school at 18 in June. And so I hadn't really had any career other than, a part-time job. So this, as far as radiology goes, it has been my lifelong profession.
All right, awesome. Thank you. So could you guys talk on these soft skills that you would need to have for these positions? Like, what is the patient interaction? How much patient interaction do you have? Just along the lines of that.
For radiology, our students and our technologists need to have very good communication skills. They're going to be working with all types of patients in all different, they're going to be in different, the patients are going to have different backgrounds and they're going to have different things going on with them. So we need to have someone who is capable of communicating with someone who's able to communicate with them easily, as well as with patients who maybe aren't as easily able to communicate or who are in the worst, having the worst day of their life. So communication is a huge soft skill that we need students to have. The other thing that's very important for radiologic technologists is they need to be able to think critically. Oftentimes we'll have, we teach you how you're going to do a textbook patient, somebody who can walk in and lay down on the table and do everything that you need them to do. But in real life, that's not how patients come into you. They come in, they're beat up, they're in pain, and they're not always able to do things the way that you need them to do it. So you have to think critically about how you're going to modify that exam to get it completed for a patient who's unable to do what you need them to do. So for us, again, communication and critical thinking skills are those really important soft skills.
All right, as far as surgical technology is the interactions with the patients, like really the amount that we actually will speak to the patient, there's not a whole lot of conversion between you as a surgical technologist typically and the patient. If you think about it, we're already in the operating room, we're gowned and gloved and all ready to go. Pretty much all the other members of the surgery team will go and speak with the patient prior to surgery. So like the circulating nurse, the surgeon, the anesthesia provider, they have a lot more interaction, like actual speaking time with the patient. A lot of times in a surgery, about all I'll say to the patient, they will roll into the room. I'll introduce myself, be like, hi, I'm Jeremy Wilson, or hi, I'm Jeremy. Typically don't use my last name. And basically I ask them their name, confirm with them what procedure they're having. It's basically just little things like that, that a lot of the time it's more of a mental check for myself that yes, like everything is lining up. Basically it's one of the main things that we do before we start surgery, making sure we have the right patient, make sure we're doing the right surgery, etc. So if the patient rolls in and I say we're doing this and the patient says no, we're doing that, somebody's in the wrong here. Most likely it's me. The patient clearly is going to know what they have going on. But as far as the communication skills, it is very important. Even though we don't speak with the patient a whole lot, you have to be able to be ready for anything in surgery. Kind of along the lines of what Mallory was saying, pretty much you can guarantee one thing, it's going to change. Whether it's going to change because something isn't going right in surgery, or it's going to change because the surgeon wants to start using a new set of instrumentation, or whether it changes because the patient has a range of motion limitation, so we can't position them into the normal position we would put them in order to do a procedure. So you may be asked, or part of that planning of, this patient has very limited range of motion. What are we going to do to get them on the operating table and in a position that is comfortable for them, but functional for us to be able to complete the surgery? So that's basically the whole critical thinking aspect that Mallory was talking about. It's pretty much hands down across the board. Any medical profession you go into, critical thinking one time or another is going to come into play, and it is very vital. And we also preach, it's not necessarily soft skill, but it's more of a physical thing. Like people will come in, you can come in working out nonstop and come in the best shape of your life. It's a totally different style of physical exertion in the operating room than what it is to go run a marathon or whatever. Because like you look at it and you're like, oh, that isn't that bad. You're just standing all day. But we stand and we don't move very much. So that's one of the things I'll harp at my students: get a good pair of shoes, clinical shoes, because I guarantee you your feet and your legs will hurt. Especially after you spend a whole semester sitting in the classroom and you go and stand for 6 or 7 or 8 hours, it's going to make your feet and your back hurt, guaranteed. Because basically once we get set up and ready to go, and even while we're setting up, we're taught not to move very much. Basically, the more you move, the more air current you make, the more chance of your instrumentation becoming contaminated. So that's the whole idea. We're basically standing about a 3x3 square.
All right. And that advice about the shoes, if you are going into anything where you're going to be doing clinical training, shoes are very important. So remember that. So it sounds like, just kind of based off of how you describe the patient interactions, if you're wanting something that's more, a career that's more patient interaction, you might want to do something radiology technology. And if you were wanting less patient interaction, maybe surgical technology. However, what kind of patients do both of you typically see in your careers?
We see them all in radiology. We're going to see, your general patient walking in to have a basic study like a mammogram, all the way down to, we're going to see COVID patients. We're going to see patients who have been injured and maybe are incoherent. We literally see every patient that comes into the hospital in radiology. So I generally tell students, we get a lot of students who will come to us and say, I don't think that nursing is for me because I can't do blood, I can't do guts, I don't want to communicate with patients, or I can't do sick patients. Well, if that's you, radiology probably isn't the place, because you are going to see every type of patient in the hospital in the radiology department.
Pretty much with surgery, you got to figure we're seeing everybody, like nobody's happy to see us, we'll put it that way. And on radiology, maybe you still got to hope that maybe there's nothing wrong with you. And you'll be able to get away with the whole, they're going to tell me it's just a bad bruise or whatever. But basically, once they get signed up to see us, pretty much that's one thing you have to keep in mind with an OR. You get very accustomed to being in there, it's normal to you. But then you think about, if none of you had surgery, essentially, what do we ask you to do? We ask you to put on a thin gown. Depending on what type of surgery you're having, you may not have anything on underneath it. And they're going to bring you into a room that's 68 to 73 degrees. That's what we keep the OR at. If you ask the surgical people that scrub in, they're going to want it closer to that 68 because it gets quite warm in there whenever you're standing beneath operating lights and everything. So basically, we keep it cold. So then essentially, it's a really foreign environment to everybody. So we see everybody, but we typically see people on they're not so great days. Or you could be seeing somebody they know they have cancer, so they have that aspect. Or you could get a little kid that's scared to death because now you're definitely looking foreign to them in gown and gloves and masks and everything. Plus they're cold, and plus we just took them away from their parents. So basically, in the operating room setting, we see everybody on their worst day. So you'll see like strange behaviors, like you learn about this in class about people. You may get a 50-year-old man acting like basically like an adolescent kid. It's actually something known as regression. It does happen. So or either that, or you get somebody in with the whole nervous laughter, or so you'll hear and see like weird things from patients. So basically, it's just one of those things that you kind of just take in stride of the fact that it's this stressful environment. They're scared, based like pretty much everybody that comes to see you in surgery, whether or not they'll admit it or not, they're at least anxious to a degree. No, but like I said, nobody wants to be there. So we do tend to see some slightly different behavior sometimes from patients, or you may get that patient that's a nervous talker, so they'll talk your ear off. So normally you wouldn't spend a lot of time speaking to the patient, but they may decide it's you they want to talk to. And if you're done setting up and ready to go, you're going to be standing there having a conversation about who knows what with that patient.
Yes, I think that definitely kind of goes with that communication skill, being able to just kind of do what patients need, be able to talk to them if they need it. But so how would you guys describe a typical day in your life, in your career, and like what kind of hours would someone in this role be expected to work?
In a radiology department, most radiology departments are going to be staffed 24/7, particularly in larger facilities like Mosaic. In smaller facilities, they may be staffed till a certain point in the evening time, and then there may be an on-call technologist. But generally, radiologic technologists are going to work either an 8, a 10, or a 12-hour shift. And based on the number of hours that they work will determine how many days per week they work. Again, it may be possible that in smaller facilities that in addition to working your regularly scheduled hours, you may be taking call of an evening or on a weekend. And in a small location, the likelihood of actually being called in is pretty high. In addition to those working hours, a general day in the world of radiology is pretty busy. Usually what will happen is early in the AM, the radiologic technologist will do what we call morning portable exams, where we will go and we will do a portable exam where we take our x-ray machine. We have a portable mobile unit that we take with us to the ICU units, and we do morning chest x-rays on the vast majority of those patients. And then we come back to the department and we have a work list with all of the patients from the department that need to have x-rays sometime during that day. Some of those have a specific time period that they need to be done. Others can be done at any time during the day. And then in addition to those inpatient exams, we will usually have regularly scheduled outpatient exams for patients who are not necessarily in the hospital that need to have procedures performed. Usually the inpatient exams are going to be completed by, like by 5 o'clock, by your normal end of day. But there are always add-on patients that get put onto the schedule as the day goes on. So rad techs are working pretty hard. They're going to be busy all day long with patients in and out. In addition to those scheduled patients, there are going to be ER patients. You never know how busy the ER is going to be. And then we also usually have a rad tech that works in the surgical suite with Jeremy. So we're pretty busy. Like Jeremy said, it's one of those deals where you're going to be on your feet most of the day. You're going to be on concrete. You're going to be moving heavy equipment and moving large patients around. So it is fairly strenuous. You're tired when you get off work. Usually those people that work the 12-hour shifts, people are like, oh, that's pretty nice. You have 3 12-hour days and then you go home and you have a long weekend. Well, that's not really the case because it takes a full day to recuperate once you've worked one of those 12-hour shifts. One thing that I will say is that there are also radiologic technologists that work in outpatient imaging centers where all of the patients are outpatients, as well as in doctor's offices, and they are just doing the patients that come into the doctor's office for particular exams. So again, busy places, but not necessarily with as much variety as there is in the hospital setting.
And how many patients would you see in like a 12-hour shift in a busier location?
20, maybe more than that. And it depends on the type of exam. You can do a chest x-ray in 10 minutes, but if you're doing a fluoroscopy exam where maybe you're doing an upper GI or a study on a patient who has had a motor vehicle accident where you have to do multiple body parts, it might take upwards of 45 minutes to an hour. So depending on what types of exams you're doing, you might see 20 patients and maybe you see 10. I mean, it all sort of depends on kind of what's going on that day.
And I would assume that would be kind of the same for surgery, right, Jeremy?
Yeah, it's totally the caseload, if you will, is totally going to depend upon what the case is. You're doing, like, say you're working general surgery. If you're doing laparoscopic cholecystectomies, which is kind of a bread and butter surgery for a general surgeon, those of you that don't know, that's laparoscopic. So basically, we're not going to cut you open. We're going to use what's known as trocars. So we're going to put in ports, the whole shows on the TV screen. Like, I'm sure if you all watch medical shows, you've seen that. Cholecystectomy, though, is the removal of your gallbladder. So basically, that's something that's very common. Those procedures, like a lot of physicians can do a lap chole 20-30 minutes. So you figure 20-30 minutes for surgery. And so roughly with about an hour between setup, surgery, breakdown, turn around, start all over again. Or if you get something such as a colon resection, it could take 3 or 4 hours, depending on what we're doing. There's procedures that last 8, 9, 10, 11, 12 hours, depending on what the procedure is. Again, kind of like Mallory was saying, depending on the condition of the patient. If it's like a vehicular accident, they have multiple broken bones plus internal organ damage, we're probably going to start with the general surgeons. They're going to fix what's going on inside, and then you're going to have to bring in the orthopedic team. And you as a scrub, you may be asked to scrub both. So then you may switch over and start working orthopedics. So basically, you may work with the same patient all day long. So basically, you'll go in on a typical day. You show up a lot of the times before you go home the night before. You know what your case is, like what your day is going to look like. Typically, you work on the same rough team. So like when we talk about teams, we're talking about general surgery, orthopedics, pediatrics, plastics, whatever it may be, whatever team you typically work on, most likely you're going to come in and work with that team. So you pretty much know what your day looks like. But if you're working in a large hospital, that day obviously could change, because if you have somebody come in with an emergent surgery, it's going to bump everything. So, you know, typically 8, 10, 12-hour work days, like Mallory was saying, it just depends on what the schedule is. A lot of the time with surgical technologists, they want you to work at least a 10-hour day. If we come in at 7, that means you get off at 3. Typically at 3 o'clock, we're in the middle of a case. So they don't really like people leaving at 3 o'clock. They have to find somebody to come in and replace you. They'd rather you stay till 5, because typically by 5 o'clock, with the day is winding down. So a lot of times we'll work 4 10s. In a surgery, in a larger surgery setting, you'll have people that work 3 12s and get paid for 40. A lot of the time there's positions for that, but it's usually the more undesirable positions. What are your 3 12s? Friday, Saturday, Sunday. So basically you work all weekend, every weekend. So in order to get people to do that, they give them extra incentives. Basically we're paid with 4 extra hours that you don't work. A lot of times they get paid more per hour, because again, they're working those shifts that nobody wants to work. But a typical day though, you're going to come in, you're going to start with your first case. So basically you can go into your room, make sure everything looks good, wipe everything down, start gathering supplies for that first case. Get that first case set up. So you start at 8, typically we'll show up an hour before, so you should get there at 7. By 8 o'clock, you're ready to go. You start that case, you work that case, and then just kind of depending upon how the schedule is booked out. Most surgeons will book surgery after surgery after surgery after surgery until they're done with their surgeries. So you'll be in that room, typically working with the same physician over and over and over again. So you complete a case, they leave, you wait till the patient leaves, break down the case, set up the next case, and round and round and round you go. Most of the time in a 10-hour day, you'll get maybe, depending on staffing is really what it depends on. You may get 2 15-minute breaks and a 30-minute lunch. So becomes a medical profession. Those of you who haven't worked in it yet, 30 minutes for lunch means the person comes in to give me lunch. It's 11:30. When I walk out of that room, it's 11:30. I have to be back in that room at noon. So that means my 30 minutes starts from the time I step away from the field or walk out the door. So that's the time for me to go to the bathroom or whatever, walk down to the dining hall, eat, walk back, and get back into the room. That's your half hour. So basically you learn to eat quickly a lot of the time in the medical field. But that's essentially the normal day in a hospital. I've also worked in a surgery center. It's a little different. Like you know exactly what your day is going to look like. Tomorrow we're doing these cases. So, and that's not going to typically get added on to. If it does get added on to, it's usually not very much. If anything is going to happen, a lot of times people will say, I'm not going to do it. Because a lot of those are more elective surgeries. They're not necessarily, they don't have to be done right away. So in a surgery center, you'll see that a lot less. And then as far as call, with like the surgery centers, you don't have any call. There's no weekends, there's no nights, there's no holidays. It's closed on all those times. Versus working in a OR, everybody has call. So it just depends on what team you work on, how many scrubs are on that team, basically how it disperses out on how much call you have to take. The more scrubs there are, the less call you have to take is basically what it boils down to. There always has to be somebody there or prepared to be there. We have a half hour typically. You have to live within a half hour of the facility you work in. If you don't, they have call rooms. You can stay in the facilities in the larger hospitals a lot of times. But we have a half hour. So from the time that patient finds out, we have to be there and working within that half hour of time. And typically, the doctors are right there behind you. So it's a pretty fast pace. So that's more or less the basic overall day.
All right, and thank you guys both for discussing all different types of days to have and stuff within your career. What kind of departments do you guys work with? So like for example, you were talking about general surgery. What other types of surgery and types of radiology fields are there? And what kind of patients do you have in those?
So in radiology, we work with literally everyone in the hospital, as I would imagine Jeremy probably does in some way or another as well. But as far as sub-departments or subcategories of radiology, we work very closely. Obviously, number one, we work very closely with our own radiologists. We work with CT, MRI, ultrasound, mammography, nuclear medicine, vascular interventional procedures. Literally, we work with all of the sub-departments within our own department. But then we also work very closely with those in the ER. We spend a lot of time in the emergency room working with their physicians, their nurses, their techs. We work very closely with respiratory therapy, work very closely with the lab. We have a lot of interactions in surgery. We also do a lot of interaction with just basic physicians on the floor and their nurses. There's oftentimes a lot of questions that will have to be answered before we can actually do an exam on a patient. So for example, a physician may put an exam in for a patient who's an inpatient on the floor in the hospital, and we may have questions about that procedure, and we may have to interact with that patient's nurse. But we definitely interact with almost every other department within the hospital, and as well as physicians outside of our own hospital.
All right, as far as us as scrub techs, we don't interact that much outside of the people that, if you want to interact with us, pretty much you have to come into the OR. There's a lot of that interaction that goes amongst, because I mean, obviously surgery works with everybody in the hospital, specifically like radiology and pathology and all these other departments. Like a lot of the diagnostics, like Mallory was talking about, we are going to work with, they're going to basically identify exactly what is wrong with the patient. So that's kind of their scope, is like, this is what's wrong. And then our job is basically go in and fix what's wrong, right? So essentially a lot of that conversation and going back and forth is either done by the surgeon or it's done by the circulating nurse or whatever. Primarily for us in the scrub rule, we're primarily just working with what's going on actually in the surgical room, in the actual OR. So like Mallory was saying, if you come into the operating room, so say you have a new rad tech that comes into the operating room, one of the main things, one of your main responsibilities of the surgical technologist is to protect your sterile fields. In other words, you have a back table with thousands of dollars of supplies and instrumentation on it. If somebody comes in and bumps into it unsterilely, basically it's contaminated at all, we have to throw it all away and start all over again. So one of our main jobs is the basic protection of that field. Whenever they come in with their C-arm to take those x-rays, it's our job basically to drape out that C-arm. And then again, if it's like, if you can tell the x-ray tech is like basically not comfortable in the room, we'll spend a lot more time talking to them and basically trying to help them remember what they learned in school. Basically, don't go into the OR, don't touch anything in blue if you're not surgical, if you're not sterile. Pretty much majority of the drapes we use are blue in color. But anyway, a lot of the other things other people will deal with is like product reps or whatever. So again, I talked a little bit earlier about if a surgeon wants to switch out the instrument set that they use for whatever reason, it's a newer procedure, so it's to be faster, more efficient, better outcomes for the patient, whatever it may be. So basically, we may have a completely new instrument set that nobody is familiar with. So we'll have like product representatives in there. So they stand in there as a non-sterile member in the room, and basically they're trying to guide you through helping you figure out how their instrumentation works. So a lot of times it's kind of like a cat chasing a laser pointer, because they literally have laser pointers and they will point at instruments and say this goes in there and that goes in there. They'll do that for us. They also do that for even the surgeon in the middle of the procedure. If they have a question, that's who they're going to ask. They're going to ask that product representative. So basically, that's more or less who we deal with personally as scrub techs. But in the big picture, of course, we're working with every department throughout the hospital. Everything from a tech up on the main floor may be responsible for bringing the patient down to the surgery department or whatever it may be. So in the big picture of things, we're working with everybody in the hospital, but on our scope of like what we actually see as surgical technologists, we pretty much only deal with the people who are actually in our operating rooms.
All right, thank you guys both for those great career intros. We're going to switch gears a little bit and talk about education and training. So what is the education and training needed to become a rad tech or a surg tech?
So as far as rad tech goes, you have to have a minimum of an associate's degree in order to be eligible to take the registry exam. That's not to say that that's the only method of taking that exam or being eligible for that exam. Some schools provide a bachelor's degree, but the minimum requirement is an associate's degree. Some programs, I was previously with Hilliard Tech Center, and we were obviously a technical center. We were not a college, so we did not offer an associate's degree. So what we did in place of that degree is we would articulate with a college who would provide the general education courses, and then our students would come to us and take the radiology portion of that, and the two together would allow them then to have the associate's degree. So that may be an option for hospital-based programs. Some hospital-based programs in our area, like St. Luke's, they have a hospital-based program and research. They would have to have the students complete the general ed courses in addition to the radiology courses to be eligible to sit for the registry. North Central now, however, is going to be offering the entirety of the program, so students can take their gen ed courses and their prerequisite courses through North Central, and then they can take their radiology courses through them as well. So as I said, a minimum of an associate's to be eligible to take the registry exam.
Okay, and so since you can get your bachelor's or your associates, is there like a preference, or is there a trend for more people with an associate's versus a bachelor's?
That's a great question. Actually, there is not, an employer is never going to say to you, do you have a bachelor's or do you have an associate's? They're going to say, have you taken and passed the registry? A lot of people they will think that just by virtue of the fact that it's a higher degree, that it would be better or more beneficial to have the bachelor's degree, and that's not always the case. There are some circumstances where it is more beneficial. An example of that would be if you think at some point in your career you might like to be a departmental manager, or perhaps you might want to work in education, that bachelor's degree would be beneficial. But if you plan to work clinically as a rad tech or some other type of tech in the radiology department, an associate's degree is sufficient. There is no pay increase for having the bachelor's degree. So we tell students, if you want to go into management, you definitely need to look at that bachelor's degree. But if you're just looking to work as a clinical tech, you should be fine with the associates.
Thank you.
All right, as far as surgical technology, it is an associate's degree. That is actually something that our accreditors have just enforced as of August of this year actually, saying that moving forward, in order to sit for the CST exam, you have to have an associate's degree to go along with that. Now, there are programs out there that are not accredited. So basically, what does that mean? It means you can go and they will teach you basically the fundamentals of how to be a surgical technologist, but when you get done, you cannot sit for the CST exam. In other words, you never have the title of certified surgical technologist because the program you went through was not accredited. So that's kind of one of those things you definitely want to keep in mind. NCMC clearly is going to run an accredited program. Basically, with the program, the way it works, essentially, depending on, it all depends on how motivated you are as a student. So say you're a senior in high school and you haven't taken any college classes or whatever, you can actually graduate in May, start in with that first summer, even if you want, or you don't even have to use that summer classes. And basically you can take all of the prerequisites you need to get into the program and let's graduate with the associate's degree within 2 semesters. So within the fall and the spring semester, basically you're going to get everything you need to have done. So in order to get into the program, the ones that we are most concerned with, the ones that are the actual prerequisites for the surgical technology program, are medical terminology, microbiology, and anatomy and physiology. Those are the classes you absolutely have to take in order to get in. The rest of the other associate's degree classes you can technically take while you're in the program. I would not recommend it. Basically, the program for surgical technology is 11 months. We start in June, graduate in May. So basically you go from knowing nothing about surgery to knowing everything you need to know in order to go into surgery by the end of December. And then in January, you spend the majority of your time in that clinical setting. So the summer semester is 11 credit hours, the fall semester is 15 credit hours, the spring semester is 12 or 13, I don't remember which. So it is a full load on its own, but it is possible for you to take extra classes while doing that. Now you have to have all of your classes completed by that spring semester to graduate on time. Otherwise you won't be able to get, basically you just don't graduate. What you did does not count. Because you basically be set for the CST exam in May as part of the program. And in order to sit for that CST exam, basically we have to submit saying that you're going to obtain your associate's degree when you graduate in May. So that's essentially the educational line for surgical technology. When I graduated in 2015 from Hilliard, it was just a certificate program, so you didn't have to have an associate's degree. At that time, NCMT was actually offering the needed classes, because there was only like 3 or 4 classes that you would have to take extra above and beyond what we did in the class in order to get your associate's degree. But anyway, at this point in time, it is mandated by the accreditors that it basically has to be an associate's degree.
And does that change the responsibilities within the position at all, or is it more just like titling?
It has nothing to do with what we learn. We learn exactly the same thing. What I teach my students is exactly the same thing I learned as a student. Basically, all it does really is, instead of, say, you graduate from high school and you take A&P and stuff like that in the summer, you just start right away. And so basically, just more or less, it added an extra year before you can start working, really. Because if you don't do anything in high school, you got a year of prerequisites, 11 months with us, and then you can go out. But as far as what you do for a job, it's exactly the same. It's just something that the accreditors have basically decided that that's what needs to be done.
All right, so like having an associate's degree just kind of allows for more prerequisite classes, and then you kind of get into the program and start taking the surg tech or the radiology tech classes. What are the classes and clinical training like?
So I feel like I probably should elaborate just a little bit on our timeline. Jeremy did a really good job of that, and I didn't talk about what our timeline looks like. Our program is actually a 2-year program. The radiology program is a 2-year program. And for our program, all prerequisite courses have to be completed prior to starting the program, which will begin in June of 2022. So all prerequisites would need to be done prior to that summer semester. And our program itself is actually structured in that both summer semesters, the first summer and the summer in between year 1 and year 2, are 6 credit-hour courses, or you take 6 credit hours, and then each fall and each spring are 12 credit hours. So basically, we felt like those semesters were so jam-packed that there was no time for a student to be taking any additional courses beyond the radiology courses, and that's why we have those as prerequisites. I think you asked a little bit about what do the courses themselves and the clinical components look like. Is that correct, Savannah?
Yes, that's correct.
Okay, so as far as our courses go, I feel like you probably kind of want to know how things are laid out. So basically, what students can expect is that in year 1, they are going to come to class 3 days per week, and they're going to go to clinicals 2 days per week. And then in year 2, that will flip-flop. So in year 2, they will come to class 2 days per week, and they will go to clinicals 3 days per week. Classes in year 1 are going to be basic classes like radiographic procedures, where students are learning how to position a patient for each different exam. There are some other classes sprinkled in there, radiation physics, lots of different science type courses that go along with that in year 1. And then as we get into year 2, students see more advanced courses, things like cross-sectional anatomy, advanced imaging modalities, and at the very end, we have a registry review type course. As far as clinicals go, students go to clinicals 8 hours per day, and they are going to be going to a variety of different types of clinical sites. We expect each student to go to a large facility, which would be like Mosaic, for example. They'll go to a more regional sized hospital. Maryville, for example, is a regional sized hospital, and then they'll go to at least one regional hospital, and then they'll also go to a clinic site over the course of those 2 years. The clinical training is pretty intense. We are pretty rigorous as far as what the expectations are for students. And we really expect that students will get in there and learn what they need to be doing as a radiologic technologist while they're at the clinical setting. I'm not sure if that totally answers your question or if you were looking for something additional there.
Oh, no, perfectly.
Okay.
Thank you.
All right, as far as the breakdown for surgical technology, essentially in the summer, it's kind of all of the foundation. So you have like pharmacology, you have introduction to surgical technology, and they have a class that basically circulates around care of the surgical patient. So it's kind of laying a foundation. In the fall semester, like really, if you think about it, it's very fast paced. So even by the time we hit fall, so in the summer, you don't actually learn a whole lot about what we actually do in the operating room. Once we hit fall, we have fundamentals 1 and fundamentals 2. Those are two 8-week classes that divide the fall semester up, and then you also have surgical procedures. So essentially, what you do in fundamentals is you learn all the fundamentals, like I said. So you learn everything you need to actually know in order to set up a case. So that basically everything from what is all of this different operating room furniture, if you will, to how do I go about this? What do I do if I mess up something? How do I fix it? So that's fundamentals. And at the same time we're taking fundamentals, we start to went into procedures. And what we focus on in the fall semester of procedures is we focus on the surgical specialties that we know you're going to see in the clinical setting. So we know you're going to see general surgery. We know you're going to see plastics. We know you're going to see ortho. We know you're going to see ENT. So you're going to have those chapters out of the book. That's what you're going to learn in procedures. So really, it's 15 credit hours. You're going to be in class 4 to 5 days a week. So basically, with the fundamentals class, there's 2 lab components to go with that. So we lecture 2 days a week in fundamentals for 2 hours and 45 minutes, and then you're in lab for 8 hours a week for fundamentals. And then in procedures, we lecture for 2 hours and 45 minutes, and you're in lab for another 4 hours. So you're in lab a total of 12 hours a week in that first semester. It's very important to spend that much time in lab. Is basically you'll see myself and then my fellow teacher basically demonstrate a skill or talk about a skill, and you think, wow, that looked really easy. And then you step up and try to do it yourself and realize, hey, they've done this thousands of times. That's why it looks so easy. It's really not that easy at all. So that's why we spend so much time in lab. In the spring, on the other hand, basically you only come to class 2 days a week. Monday and Friday we have class. Tuesday, Wednesday, Thursday, you're in clinicals. So Monday, typically we'll do procedures too. So that's the more less common procedural techniques that you guys will not maybe not even see at all in clinical, such as ophthalmics or whatever. Excuse me. And then we also on Fridays we do what's known as a capstone course. Basically, that's just there as a review course essentially for the CST exam, but we also do like resume building and things like that. But Tuesday, Wednesday, Thursday are 3 days a week that we do clinicals. Basically, at clinicals from anywhere from 6:45, 6:30, 6:45 in the morning is typically what time you get to clinicals as a student. Because most cases we want you there at least an hour and a half before the first case as a student. So we want you there basically, we want you there definitely before your preceptor shows up. Because you're going to go, and essentially what we expect you to do is step right in. You know enough as a student to do it. It's just whether or not you can trust yourself to get over that hump. Basically what it is, you have to jump in there and do it. Not only do you have to jump in there to do it, because you have to get, basically in order to graduate, you have to have 120 cases in surgery. That means you actually scrubbed in and functioned as a surgical technologist for 120 cases. We don't have that many days really within the clinical setting. We have roughly 30 days. So in order to get your 120 cases and graduate on time, you have to average roughly 4 cases a day. Doesn't sound like that much, but sometimes we have slower days in the OR. Sometimes you'll get put into a case that lasts 4 or 5 hours. That takes like over half of your day as a clinical student. So it is very important for students to get in there and jump right in. Not only that, but we have your preceptors basically evaluate, they let us know. We try to build the best relationship so that they will be honest with us. We want to know basically when our students are screwing up. They don't tell us, you don't tell us. How do we know what to work with you basically on Mondays and Fridays so that you quit making those same mistakes? That's basically how it's broke down. It's very fast paced. It's a lot of information, especially in the fall semester. Like, it's best to have everything you need to graduate with your associate's degree done before you come see us. It can be done, but you're just asking for basically a rough time. Because if you think about it, you're spending roughly 20 plus hours a week actually in class for surgical technology. And then we expect you to study 2 hours at least for every lecture hour you spend with us. So just when you figure that out, you're spending 40 hours a week roughly. Is what you should be spending just on surgical technology alone. So it's very fast paced, but it's only 11 months. So basically, so you gotta tell yourself, really, once you make it through the fall semester, once you hit spring, other than going to clinicals, which is really stressful, but once you hit spring, I tell my students, that's the fun semester, man. You actually get to go and do it. Like you're in there scrubbing in, like basically, you know, it's a little gory, but you're in there getting blood on yourself, man. Like this is what we've been training to do. You're in there, you're working. We're not simulating anything. You're there with the actual patient, actual surgeon, you know, getting it done.
I think that's something that's really cool about both Surg Tech and radiology is you get to get that clinic experience really early in your education. Is there anything else that you guys, this is going to be the last question, by the way. Is there anything else you would like to talk about with the programs you have going on in Savannah, or what type of student would be best for this type of program?
So I just have to say that, and I think Jeremy would attest to this too. Jeremy, I'm talking for you and I'm sorry, but we are both very excited about the opportunity to come to Savannah and to have these allied health programs available to students in our area and for our community. And I personally think that we have some of the best instructors, and I think that there is a huge need for both surgical technologists and the different types of radiologic technologists. So we are looking for students who share that excitement, and students who are ready to get in and willing to learn. What I would tell students, maybe as some of that, you know, off the cuff advice or unofficial advice, is that I'm not necessarily looking for the perfect straight A student, although I like that. I'm looking for somebody that has those soft skills. Some of my very best students that I can think of in the past, I had one student in particular who, again, she was not an A+ student. She was not valedictorian of her class. She was a mom of 4 boys. She drove in every day from Chillicothe. She missed very little time and she worked very hard, and now she is very successful. So those are the types of students I'm looking for, the ones that will show up and put in a day's work. And if I ask you to do something, you're willing to do it, and you're always looking to improve. So again, if you're, you know, maybe not the best student, or you are not necessarily the A+ student, but you have those qualities, I know that I would definitely be looking for a student like you.
I'll echo a lot of what Mallory was saying. Like, you know, just because you're not the best student of actual book learning, but you thrive on hands-on, well, essentially like half of what we do is hands-on. Yes, the book learning is very important. Yes, the book learning, like basically you have to figure it out in order to pass the CST exam. But like essentially my teaching style, and most likely the individual is going to be my co-teacher, like we really pride ourselves essentially on our students doing well. We want nothing more than for our students to succeed. So essentially, if you show up with the understanding that yes, we may bark at you, or basically you may think we're riding you, but we're riding you because we actually care. We're riding you because we want you to do well in these skills, so that whenever you get out into the actual environment, like I've had students tell me, because I'm 6'6", I'm a big guy. So I've had students tell me, like, you make me nervous when I stand next to you, and I always laugh at them and say, if I make you nervous, you got a whole, you know, I want you, I'm basically your peer. Once you graduate and get your CST, I'm just your peer. So if I make you nervous, you have to get over that fact. So if I make you nervous, or students like act nervous because I'm watching them, that's why I'm going to watch you more, because you have to break that. Because I guarantee you, if my presence makes you nervous, whenever you go into the surgery setting where the surgeon's standing there, you're definitely going to be nervous. But it's the whole idea of basically, if you're willing to put in the effort, I guarantee you will be successful if you legitimately try. Because I will basically tell you everything you need to know. Basically, your book tells you everything you need to know. Then I'll tell you everything you need to know. By the time you get to the test, it should be like, oh, I need you to know that. So that's pretty much the way I always tell my students. If you flunk one of my tests, I'm going to shrug at you and say, you should have studied harder. Because basically, that's the way I look at it. By the time you get to the test, you should know what's on that test. So if you don't know what's on the test, it's simply because you didn't study. So that's more or less what I'm going to come back to. The first thing I'm going to ask you is, how much did you study? Or are you, basically that's the approach I'm going to take you down. Now, if you are struggling with it and you come to me before the test and say, I just don't understand it, then I'll stay after for hours if I have to work on skills or whatever with students. We can stay extra, and I'm more than willing to do it. Mallory and they're more than willing to do it as well. If you guys just have the drive to be successful, we will do everything we can to make you successful. We can't guarantee it, but we will do everything we can so that you are successful as a student.
Thank you. It's definitely important to build those study skills. If you haven't had the opportunity to learn how to study yet in high school, definitely recommend finding a way to figure that out before you start college, because it's definitely something that you kind of need to have mastered by then. Let's all give Mallory and Jeremy a hand for taking time out of their day to talk to us. If you have any questions, please post them in the chat. I am going to launch